Thank you, madam, for the excellent talk. Now we'll move on to the second talk by Dr. Anagha HeroorD. As we know, the cataract surgery has become a refractive cataract surgery. So she will be talking on angle alpha and kappa, their relevance in cataract surgery. Over to you, madam.
Yeah. Thank you so much, sir. Very good morning to all of you. Thank you, Dr. Arup, sir, for giving me this opportunity. So I'll be speaking on the relevance of angle kappa and angle alpha in biometry and in cataract surgery. No financial interest. So we'll be discussing on what exactly is angle alpha and kappa, how do we measure it, what are the implications, and which patients are most at risk. So today with the premium IOLs that are on the rise, we can get functional good vision at all distances. But also the leading causes of dissatisfaction is dysphotopsia and reduced contrast sensitivity. For example, we have this patient here operated for a multifocal IOL, 6.6 N6 well-centered lens on the pupil, no other problem, but patient is still unhappy. Now, in order to answer these questions, let us look at some terminologies. Now, for example, here, the first is you should know that the optical center is the center of the cornea based on the limbus. Then we have the pupillary center, which of course is the center of the pupil. And then we have the visual axis. Now, there is a terminology called as the SFCS-CLR, which means it is a subject fixated, coaxially sighted corneal light reflex. Simply put, when the patient is under the microscope and asked to look at the light reflex that you can see on the cornea is where you're going to mark the IOL centration. And that is not affected by pupillary dilatation. That is the visual axis. Again, you have three axes. The visual axis is that which joins the fovea to the fixation light. Then you have the optical axis, which passes through the center of the cornea, center of the lens, and is slightly nasal to the visual axis. And then you have the pupillary axis, which is perpendicular to the cornea to the pupillary center. So the angle kappa is basically, you can see now there are three colored dots. The yellow is the visual axis, blue is the pupillary center. So the angle kappa is between the visual axis and the pupillary center. So a mnemonic is PVK, very easy to remember. It's about usually around 5 degrees, usually on the plus side. Then you have the angle alpha, that is between the yellow and the green, that is between the visual axis and the optical center. A mnemonic is OVA. So this is the angle alpha. Now in this patient, as you can see, all the three dots are very closely spaced in the center of the IOL. So which means that in this patient, the visual outcome will be much better. Now in contrast to that, if you look at this patient where all these points are little farther spaced, so there is a greater difference between the distance between the visual axis and the pupillary center, the visual clarity and performance will not be as good. So what is the ideal placement actually for a multifocal IOL? So it is said that the best centration of our multifocal IOL is between the visual axis and the pupillary center. So actually that is a chord. It's not just an angle. So that is why it is denoted by a chord mu, which is approximately 0.3 millimeters. The visual axis is nasal to the pupillary center. So definitely we need to ensure that our lenses are centered well on the pupil and on the visual axis. So we need to look out for patients who have large angle kappa. Why is it important? The reason is because multifocal IOLs are sensitive to tilt and decentration, which decrease the optical quality. So what happens if you have a large angle kappa? You have a risk of photic phenomena. What happens if you have a large angle alpha? It may lead to poor centration of the IOL, and this impairs post-operative visual performance. So along with the preoperative workup of all the K-metries and the axial length, angle kappa and angle alpha should also be ideally measured. So how is it measured? Very simply, if you look at the patient clinically, you do a cover-uncover test, you see that the corneal reflex is not exactly in the center, it's slightly nasal. If there is no shift on cover-uncover test, that means there is no strabismus. If there is a large angle, positive angle kappa, you can see that the corneal reflex is more nasal. It gives an effect of a pseudo-exotropia. If it is a very large negative angle kappa, the corneal reflex is temporal. So that gives an effect of a pseudo-esotropia. If it's a very large vertical angle kappa, the reflex is above or below, that gives an effect of a pseudo-hypertropia. Now, how is it exactly measured? So you can use either topographers, OBSCAN, optical biometer, eye trace, OPD scan. Each device will give a different technique, different quantities. So you cannot definitely equate them together, and you need to know your device properly. Now, for example, here the IOL Master 500, that uses the PX and PY. So you add both these magnitudes, ignore the sign. Similarly in the lens star. So the addition or the sum of the magnitude should ideally not be more than 0.6 millimeters. If it is, then it gives a higher risk of halos and glare. The IOL Master 700 uses the CWC, like I have highlighted it. That is the Chang wearing cord. So that gives a measurement like 0.4 millimeters at a particular angle, like here it is 314 degrees. You can also use the Pentacam here, and you can compare it. Here again you can have the white to white values here, 0.5 plus 0.1 on the right eye, 0.3 plus 0.2 in the left eye. And you can compare it with the Pentacam. Now this was a patient with a topography, this is the Atlas 9000, that will give in X and Y coordinates. So this patient had a high vertical angle kappa, the Y coordinate is almost 0.8. So which patients are more at risk? These are the high hyperopes. Now this was an article which measured the angle kappa in myopes and hyperopes and looked at their role in multifocal IOL implantations. So what they found in myopes, most of them have a negative value and most of them have an angle kappa less than 0.4. Whereas in hyperopes, most of them have a positive value and a significant number had more than 0.4 millimeters, which is at a higher risk of IOL decentration. So what are the implications of all this? Now this is important not only in multifocal but also in the negative aspheric IOLs, because more than 0.4 millimeters of decentration causes the IOL to lose its properties. Especially in multifocal IOL, it increases the night vision phenomena and decreases the visual quality. So large angle kappa, how large is large? So it is defined as the value that exceeds half of the diameter of the central optic zone of the multifocal IOL. So let's see what exactly it means. So suppose you have the central optic zone which is decentered, then the fovea-centric ray will hit the edge of the ring, will not pass through the central optic zone of the ring. Now especially if it is more than 0.5 millimeters, it can cause deterioration in quality. So in such cases, it's better to avoid multifocals. So here you can see there are two multifocal IOLs. The one on the right has a 1.4 millimeter central optic zone. So it has a tolerance to angle kappa of 0.7 millimeters. Whereas if you look at another one which is 1 millimeter, you have just a 0.5 millimeter tolerance to angle kappa. So whatever the central optic zone, if it is larger, like in this case a 1.4 millimeters, it is more resistant to large angle kappa. Now, for example, if you have a large angle kappa along with an IOL decentration, then you have a cumulative negative impact on the vision. So that is why it is important to note all of them. This is another article which measured the changes in angle kappa and angle alpha before and after cataract surgery. Now, do we know that these angles actually change? So yes. So what they found was the distribution of angle alpha is more organized compared to angle kappa. The magnitude of angle kappa, not the orientation, mind you, the magnitude changes many times after phacoemulsification, it reduces. But angle alpha does not change, and that is why it is probably more reliable and a stable factor. This was another article which looked at the role of angle kappa in these patients, and they found that if there is a more than 0.4 millimeter, incidence of glare and halos increased. More than 0.5 millimeters, the visual quality also decreased. Now, does it affect only multifocal IOLs? Not necessarily. If it's a zero aspheric IOL, it may not matter much. But if you look at the lower part of the slide, in a negative aspheric IOL, if there's a decentration of more than 0.5 or 1 millimeter, it significantly affects visual quality. Now, how do you center the IOL? All these diffractive IOLs, multifocal IOLs, centering is more critical. The pupillary size will determine the number of active diffractive rings that will be seen. And these should be ideally concentric with the pupil, but it should be lined up with the visual axis for best visual performance. Now, for example, here you can see we are aligning the center of the optic zone of the multifocal IOL on the two visual axis. That is, you switch off the oblique light and ask the patient to fixate on the stereoscopic axis, and then you fixate it. So you're actually fixating it on the visual axis. Now, what do I look for post-operatively? Once the case is already done, you can quantify the decentration of these lenses. For example, this was a patient where you can see the multifocal IOL is centered well on the pupil and the visual axis is also centered. This was a patient where you can see that white dot is at the periphery at the edge of the ring. So it's not on the visual axis, and patient experienced glare despite a perfectly centered IOL on the pupil. Now, for example, this patient, you can have this OPD scan NIDEC. It actually measures exactly the angle alpha. Here, this patient had a very high angle alpha and kappa, so these are not ideal candidates for multifocal IOL. The P distance that you can see is just 0.45 millimeters. It makes a good candidate for a IOL, multifocal IOL. So which is more relevant, angle alpha or angle kappa? So we know that the angle alpha does not change. It's related to the limbus in both photopic and mesopic light conditions, and that is why probably it is a better parameter. Post-op angle alpha was found to have a negative impact on near vision, and post-op large angle kappa showed a negative correlation with uncorrected intermediate visual acuity. So to conclude, the key is to select patients who have a small angle alpha and angle kappa. So that means the optical center, visual axis, and the pupillary center should all be tightly placed in the same central zone. Thank you so much for your kind attention.